Thank you, madam, for the invite. Thank you, Uday sir and AOS Adverse Events Committee. So, what I'm going to talk in the next 10 minutes is about various scenarios of clusters in what all way they can present. You can go to slideshow. Yeah, thank you so much once again. It's a smaller crowd, but for the magnitude of problem that is occurring in the country now, this is a very warm vanakkam from all of you from Tamil Nadu, Coimbatore. Sir, it's not moving. Okay. So the idea is to, just to make you aware, it can present in many, many forms. Nothing against anybody. From doctor as a role model, as a god, we have gone into patient centered now, and patient knows everything more than us sometimes. So when it becomes an infection or cluster, it becomes difficult. Most commonly performed surgery in the world, and more than 8.3 million surgeries done in India alone. So, sir has given you that when you see an end of post op, be it one case, it's a real nightmare. It's going to be big nightmare. But when you see many of them like this, it's a nightmare of nightmares. So, from the era of where we were couching, now we have gone to modern theaters. Our protocols have changed. No more. We have gone into HEPA filters with AHU. We have gone into horizontal autoclaves, which are well validated. We have moved to era of class 6 validation, but Bovidix and so on and so forth, to make sure our process is absolutely fantastic. And this gold standard biological indicator has transformed the validations, and with so many protocols, still are we safe? We have intracameral drugs, everything being given, and the number of end-off have reduced multifold, sometimes 4 to 5 times in the country. As by Arvind's study, you know how much it has reduced. So the antibiotic policy also is now comprehensive. It is towards the prevention of end-op, pre, per, and post-op. It can be end-off or it can be a cluster of TAS. Surgical site infections are within 30 days of the surgery, but when we put an implant, then it becomes within 90 days. This is the definition of a surgical site infection. 5 cases or more are defined as clusters, but I would advise, even if you get 2 on a single day or on 2 consecutive days, take it as cluster and work towards it. So hospital acquired infection, sterilization breakdown is one of the most important things. Consumables where sometimes we do not have any, even if you do batch testing, there could be one where many things between the producer and to the place where we are consuming, the transport is there. So many things can happen, and single case can become multiple because of our protocol. This is one of the alerts that has come in Indian journal. 1 in 100 it's an alert, 2 in 600, 1 in 75, red alert is 2 in 200. So these things are important for us to wake up and make sure we don't go on to get clusters. Now coming to my topic, botched eye surgeries. This is the commonest term used by the media anywhere and everywhere. What do we mean by botch? We have messed it up totally. We have done something bad. We have done. That is what the people also think when they see the media. It is very interesting for the people who make a news of it, but when the person reads, it is the name of the surgeon, it is the name of the hospital. So these are various things we see in the papers and the various channels. This is one scenario, one of the biggest in our country, where 65 cases all operated went in for cluster endophthalmitis. It was shown that it was Pseudomonas gram negative, and unopened bottles of ringer lactate had this organism. So then it went to court. Then there was this thing. After the court verdict, which was in favor of the hospital, there was a human rights commission which went and said there is something wrong. They've consumed this, that, and all. It went into CBI. So it went on for a long period, almost a decade, went on and on. Imagine the trauma, not only for the two surgeons, for the management, but also for 50 employees who were called to CBI in Chennai to be interrogated. It is not a joke at all. Ultimately, what happened was the hospital won, but they had to spend crores of rupees, and compensation were given to the patients. In scenario 2, on first post-op day, 15 of 23 cases developed a TAS. And morning the surgeon and everybody saw, and then immediately the beautiful limbus to limbus edema, there was some kind of AC reaction. Steroids were started, cycloplegics were given. By evening only, many of them became all right, and within 2 days, all of them became all right, and it was a happy ending for both the patient and the doctor. So, very happy. So, what happened 6 months later? Again, the same two surgeons operated. 12 out of 25 cases, similar finding. Again, limbus to limbus edema, ASC reaction. So, they believed it is the task, and the same kind of management was given. So, one was a visiting surgeon, the other one is a in-house surgeon. Evening, that surgeon calls and says, out of 12, 7 or 8 are little better, others are same, something like that. But the next day morning, all of them turned out to be a cluster end off, and it was due to gram-negative pseudomonas. What was happening is the IV steroids was suppressing the inflammation on day 1, gave a false hope that it is not an infective case. So again it went to court and all, but the protocols were good enough. Then actually what happened, they took to street, these 12 people, they brought the media, and there were about 7 or 8 departments which came in. End of the day, it was proven the unopened bottles of ringer lactate from one company had pseudomonas. But when it went to court, all other protocols were proven. But the hospital went against the company to say that it is your bottle of ringer lactate which was contaminated, causing these infections. You pay the compensation. That fellow gave one line answer, this is not meant for intraocular use. He made himself safe. Ultimately, the hospital managed, and when they realized they were trying to take money, the lawyers and other thing, then they came and took whatever compensation was given, and the case was withdrawn. So this is ringer lactate again. Now this is a case of 9 out of 12 cases at cluster end of about a couple of years back. The main reason was they were sharing intraocular consumables. Actually, if you look at the cost, it will cost you 100, 150 only. But the same consumable was used for 2 sets of patients, and not one. They were using 3 intraocular consumables. So then ultimately one of them had a same cluster, and it went on and on. But it was because of sharing of consumables. Actually, four intraocular consumables were shared between patients. One of them turned to be infected, and that was the cause for the cluster. Again, there it was a gram-negative bacteria. Now, this is another case in the south where I got reported that 40 cases were infected in 2 years, which is a big percentage for that particular hospital. So, a thorough workup was done one whole day, sitting with the team and looking at it. Ultimately, we found out it was only class 1 indicator they use. Class 1 indicator is nothing but the strips. It only says you switched on the autoclave and switched it off. It doesn't say it was done effectively. Only half the time it runs, the color will change. So they were relying on this class 1 indicator, and no class 5 or class 6 or ovoidix was used. Ultimately, the validation showed that the autoclave was at fault. And then once they set it all right, everything became all right after that. See, this is another scenario which is avoidable. We have gone, I told you, from 20 years back, these validations are no longer a luxury, it is mandatory. Dr. Haripriya madam is there, she is in charge for OT protocols at Aravind Eye Care System, and she has created a beautiful protocol, and it is not just about protocol, you have to follow it up also. This is cluster endophthalmitis in a secondary hospital where 3 or 4 cases consecutively occurred. So then after every workup showed there was no organism, and this organism was Streptococcus dysgalactiae. Ultimately, I was there with the microbiologist. We decided to take throat swabs from that was a fixed team. And that nurse who was actually assisting all the cases had a subclinical infection of the throat swab. So it was sent to even Italy at that point of time, genetically proven it was the same organism. So all these are developing into the protocol. This is another case how it presents. Now, the reactions due to an intracameral drug we have seen because of multiple batches. Recently, I am talking about multiple centers. One center had end-off and others had TAS reactions. So again, the most important, we talk about the sterility. Apart from that, the endotoxin levels are also equally important, especially when we talk about implants. Then this is the one which occurred a few years back. Multiple TAS-related reactions due to an intraocular lens, all similar ones, and the endotoxin levels were very abnormally high, and that was the cause for the TARS reactions across the country. Now, cluster of, there is one that was reported probably 6 months back. IOL injector was the cause. The fellow had changed the injector. Immediately, they had about 6 or 7 cases when they used it, and then again he replaced it. Again, the endotoxin levels, which are very important. So, other strong accusations, no, this is when they go to court. No evidence of in between cleaning. Can you imagine? It is not done by the patient. He is guided by our own people. Otherwise, where they are going to get an idea of in between cleaning of cases? Lack of communication regarding status, not clearly explained. That's why I always say, when you see on day one, it is easier and best to talk and document with signature, which is lot easier than on day 4 when they all become more agitated. Same instance, recording of communications they do today. Recording is not impossible. Everywhere, by every form they record, and that becomes an evidence for them. As well as social media, it brings us down, which may not be really justified. One case, they operated right eye, 6/6 vision, superbly doing by a tertiary care. He was very far off, about 300 kilometers. Went back to his town. I'm done. 1 minute. Went back to his town and showed to his doctor and said, beautifully done, there is no problem, but only a discharge summary says left eye done. That fellow ungratefully went to the court, and it is almost on the verge of verdict in a few months, and they proved that it was wrong because there was no informed consent for the right eye. So the court said, you don't know, you have done on the wrong eye, and the claim is 60 lakhs for a perfectly done surgery. So these are the things that can happen. That hospital which had 65 cases, it was a 10-decade struggle, and they spent 10 crores. Imagine, whatever, and a good name gone, and they are on the upway path again. They are trying to do very well. So again, out of the 12 I told you, earlier 9, 2 have gone to court asking for 50 lakhs each. It is still happening. This was one of the from the IOL company saying that they have withdrawn, recalled some kind of. So these are just the tips of icebergs. I'm sure you will all understand that we need to work, and not just work, review. We have to make sure what we are doing is good. 0% incidence is a dream, not at a reality. Thank you so much for the patient hearing.